So our next talk is What Causes Geographic Variation Drug Prescribing by David Beheshti from the University of Texas Tennessee.
All right, thanks everybody for being here. This is joint work with Seth Neller, who is at the University of Tennessee. And as the title suggests, we're interested in the determinants of geographic variation in drug prescribing. So as a lot of you in this room probably already know, spending on healthcare varies wildly depending on geographic location in the United States. In terms of the privately insured, price variation plays a pretty important role in this, but even in settings where there's minimal price variation, we still see huge variation in total spending, which is driven, not surprisingly, by variation in the delivery of care. So there's a lot of famous examples of this. We see this in rates of C-sections, we see this in the amount that we spend on end-of-life care, and we also see this in drug prescribing. Now, the causes of this variation are not entirely understood, and what we're going to do in this paper is focus on one specific supply-side component and look to see are physicians, the differences in individual physicians, an important part in explaining this variation in drug prescribing. In spending, and we're going to focus specifically on prescription drugs. Yes?
Do you have a mind, or maybe you don't care, does the drug prescribing increase healthcare spending or decrease?
So we don't take a stance on that, whether it's substituting drug spending as opposed to some kind of other intervention later on. I don't think we claim anything about that. So to kind of just restate the question or questions that we're looking at, the first thing that we're going to ask is how much of the variation in prescription drug spending can be explained by physician-specific factors. So we want to know, in short, do physicians matter? One way that I think is helpful to think about this is to consider the following thought experiment. So imagine that we randomly assign physicians to locations. So we just take physicians, shuffle them around, put them in different places. And we can imagine two different extremes and think about how the cross-sectional variation in prescribing is affected in these two scenarios. So first, imagine that physicians don't matter at all. So physicians don't really do anything. They're just totally interchangeable lemmings that we can substitute in and out. Well, if that's the case, then reshuffling these physicians across different areas isn't going to do anything to the variation that we observe because it's not the physicians that are causing this variation. Okay? On the opposite extreme, if we think of physicians as having fixed practice styles, they just do whatever they do regardless of other factors in their environment, then we would expect this reshuffling of physicians to reduce the variation that we see across areas. So in the course of answering this first question, we're also going to be answering this very closely related question which is, to what extent are physicians' prescribing behaviors malleable? So how much do they change as a result of changes in their environment? And then it's going to turn out the answer to that is quite a bit, and so we want to try to figure out what factors can explain this malleability. Okay, so is it something about these physicians that makes some more malleable than others? Is it something about the places that they're moving that's causing some of them to change their behavior more than others? Okay, now the way that we're going to go about this is we're going to use a mover's design, which is becoming increasingly more... Sorry, go ahead.
Just in terms of how we're partitioning the mechanisms here, the physician is like a conduit for knowledge. Mm-hmm. If you have these drugs, spending is going to be on the branded drugs, I guess, so they're kind of new. Some physicians learn earlier than others through a salesman, or maybe they're researching or whatever. Obviously, they take their knowledge with them when they move, I guess. Mm-hmm. Do you consider that then a physician? What would you call the physician specific factor?
Yeah, so we think of basically everything that has happened up to the point that the physician moves is potentially influencing their practice style. And so you're right that they're carrying that practice style with them as they move to a different location, and we're seeing how much does that style change. I don't know if that answers your question.
Somebody call it practice style. If they were, getting gifts from the pharma salesman, mm-hmm. As long as they continue to get those gifts when they move, we're going to put it in that bucket.
Yeah, so if they have an established relationship with the pharmaceutical rep, and that pharmaceutical rep is following them, then that's going to be part of their fixed practice style. We're going to look at pharma spending in the areas that they move, both directly to the physician and to the area, and find out that it's not doing much to change the responsiveness of the physician once we condition on the differences in spending across the area. But we'll get to that in just a minute. Okay, so we're going to use this movers design, in which basically what we're going to do is we're going to track physicians who move across geographic areas. And we're going to track their prescribing behaviors before they move and track their prescribing behaviors after they move. And we're going to compare physicians who move from relatively high to low prescribing areas and relatively low to high prescribing areas and see how their behaviors are changing. And the idea behind this is essentially that we have a discrete change in environment upon the move. Their patients, the hospital that they work for, things like this are going to change discretely upon move, while these physician-specific factors, their beliefs, their training, their preferences are not changing immediately upon the move. And so examining how much their behavior changes is going to allow us to determine kind of the relative importance of these physician-specific factors versus non-physician environmental factors. We're going to end up finding that physicians' prescribing behavior changes pretty substantially in the years following a move. In terms of what characteristics of the physician predict this responsiveness, the main thing that is going to pop out is experience. So more experienced physicians are much more set in their practice styles relative to less experienced physicians. And then in terms of the characteristics of the places, again, outside of spending that predict this responsiveness, we're so far haven't found much, but we're still kind of looking. And so kind of the headline figure that we have is that differences in individual physician-specific factors can explain about 60% of the cross-sectional variation in Medicare Part D spending. In terms of the literature, there are a few kind of segments that we are related to and contributing to. The first is just this literature about determinants of geographic variation in cost or in utilization. This is not by any means a complete literature review, but these are a handful of papers that are essentially tracking patients as they move across high utilization to low utilization areas and seeing how those individual patients' utilization changes. We're doing this kind of on the opposite side, looking at physicians moving, so seeing kind of the importance of physicians versus demand versus supply. We also contribute to this literature on determinants of physician practice style. So there's a similar paper to what we're going to do by Molitor in 2018, looking at physicians' treatment styles for heart attacks. But we're doing this in a setting looking specifically at prescription drugs, where we argue that there's more discretion. And then finally, we relate this to smaller literature on physician learning. So I'll talk a little bit about this as we go on, but essentially there's this kind of theoretical paper which argues that physicians develop some practice style in their medical school, in their residency, and then their practice styles evolve over time following this kind of Bayesian updating process as they're exposed to new information. And we're going to test some theories from that literature. Okay, so obligatory outline slide. Let's start talking about the data. So the primary source of data that we're going to use here is the Medicare Part D prescriber files. I don't know if I mentioned this, but Medicare Part D is the part of Medicare that provides prescription drug benefits to Medicare beneficiaries. And there are two data sets within these files. The first, called the summary files. And what this gives us is comprehensive physician by year prescription information from 2013 to 2019. So we can see individual physicians, and we can see basically how much they're prescribing. This contains information on every physician who prescribes to at least one Medicare Part D beneficiary in a year. And it, again, includes these different summary measures. So we see the number of patients that you prescribe a claim to, the total number of claims, the total spending on those patients, and then the total days supplied, which is kind of a quantity measure of how much you're prescribing. The files also come with information that give us similar summary measures on 3 different classes of drugs. So they break out specifically opioids, antibiotics, and antipsychotics. And something that we'll have to deal with is that for physicians who prescribe to between 1 and 11 patients, it will censor the number of beneficiaries that they're prescribing to. We'll still see costs, and we'll still see claims, and we'll still see days supplied. We just won't see the number of beneficiaries. The second data set that we're going to use is what is called the detail files. And what this is similar information, but at the specific drug level. So instead of just seeing that physician A spent a certain amount of money over the course of the year, we see physician A spent this much money prescribing this specific drug over the course of the year. And the drug is at the brand by generic level. So you think of a drug that has both a generic version and a brand version. We'll see those separately. The way that this data set works is it gives us the brand and the generic name in terms of a string, but it doesn't give us any NDC codes, which is a little bit frustrating because it makes it hard to aggregate these drugs into classes. But what we did is we spent a bunch of time essentially manually matching these drugs to drugs in the Medical Expenditure Panel Survey, which has this therapeutic class level, so we can kind of aggregate these drugs into broader categories. We also pull in information on the physicians, so demographic characteristics. We have their gender, where they went to medical school. We just earlier this week finished scraping information on where they did their residency, which we're really excited about. We know their specialty, their credentials, so are you an MD or a DO? And then we have the number of years since they graduated medical school. In terms of the environment, we know the group or their practice affiliation. We know if they're affiliated with a specific hospital. We have limited information on patient demographics, pretty much just risk scores, and then some stuff about race and gender. But that's it about the environment. So, yes?
For the patient information, like which patients and how
So the way that this works is, in terms of this data set, we'll have a measure for the individual physician that will be what is the average risk score of all the patients that you prescribe to. And it'll be, of all of the patients that you prescribe to, what fraction is black, what fraction is over 65, what fraction is under 65, what fraction is a dual eligible, so for Medicare and Medicaid. It turns out a lot of that information is censored in this data set. So the only things that we really can make use of without dropping a ton of our sample ends up being the risk scores. Okay, so in terms of the data, so here's just a summary descriptive table. The only thing I think that is interesting, or that I want to point out here, is just that if we separate out those who eventually move versus those who stay in the same location throughout the entire sample, we end up having a lot of movers, so something like 90,000 individual physicians move over the course of our sample.
How do they have so many? This is a Medicare program.
Mm-hmm.
More than a quarter are not elderly. Those disabled people.
So let's see. So under 65, yeah. So this is a combination of dual eligibles. So also people on SSI, SSDI, and yeah. So I think this is. What are the other qualifications for Medicare? Disabled, and
Yeah, so I thought it was just disabled, but I'm surprised
to see
the
that
sizable number.
that fraction.
Yeah, that's the SSI, SSD.
That's SSI.
Combination for Medicare, but we get Medicare.
Okay. Okay. Yeah, I didn't have strong priors on what that would look like, but we can double check that number. Okay, so in terms of kind of what the data actually look like, this is a map where each one of these shapes is a hospital referral region or an HHR. This is a combination of zip codes, and what we're plotting here is we're plotting just in each in each HHR, we're totaling up the amount of drug spending, and then we're dividing by the total number of Medicare Part D enrollees in each one of these geographic areas. And so we see that we have quite a bit of geographic variation. So if you take the mean of the first quartile, it's something like $2,200 per patient, whereas in the fourth quartile, it's something like $3,700 per patient per year. What we're going to ultimately do, just to kind of show you where kind of our identifying variation is we're going to consider a physician or a pair of physicians who start off in the same origin location. So look at that little red X right there. And we're going to follow a physician who moves from that little red X in Utah who moves to Texas. Okay? And this particular physician is moving from a relatively high spending area to a relatively low spending area. So our measure of how much their environment is changing is just the gap between the average spending in that origin versus the average spending in that destination. And then we're going to contrast that to another physician who starts in the same origin but moves to a different area where the spending is different. So we're going to have physicians starting in the same place, moving to different places with different levels of spending, and we're going to see how their responses differ. If we just make a histogram of essentially all these move sizes, it looks like this. So pretty much normally distributed. You don't see, on average, people moving to much higher or much lower prescribing areas. The average of this is basically 0, so people aren't changing in one way or the other, at least systematically. Yes?
Could you go back to the map? So, am I right aside from Alaska, it looks like a proxy for population density?
Population density?
Like, for example, look at California. Like
Okay.
the big spending seems to be like on the big cities.
In Southern California, yeah, but then we also have a lot of big spending, in the southeast, which is not particularly dense. I mean, I guess we also see it in the northeast. I mean, you're right that up in the north of the country where there's not a lot of people, we don't see a lot of spending. I mean, this is divided by the number of beneficiaries, but potentially this is affected by density. Okay, one interesting thing about these moves is it turns out that your prescribing behavior prior to your move, in terms of where you fall in the distribution, doesn't seem to be very predictive of where you end up moving. So what we've done here is just flipped that same histogram on its side. And then we're showing on the x-axis here, we've ranked each provider, each physician, within their HRR, in their origin location. And then we're plotting that against the size of the move. Okay, so a positive move here would mean you move to a higher prescribing area. A negative move would mean you move to a lower prescribing area. And what we see here is, again, that there's not much of a relationship, so it doesn't seem to just be the case that people who are kind of outlying prescribers in their origin move to high prescribing areas or vice versa, which we think is interesting. So in terms, yes?
Is that true for risk score and like panel characteristics?
So you're asking.
Change in those from pre-post versus.
So you're asking if we were to make it a same plot, but instead of doing change in the amount of spending, we looked at change in risk score or in these other. We haven't done that, so I don't know what the answer is off the top of my head, but we could.
There's kind of a story that especially older physicians, they're moving to somewhere where they can have a smaller practice size, have lower risk scores, and that could correlate with the HR.
Okay. Yeah, we haven't looked at that, but we could do that. And we could do that, yeah, specifically by risk scores. We could also do it by experience, like you were suggesting, and we could see if that's what's going on. Thanks for that. All right, so in terms of the research design, what this is going to look like is this is a pretty straightforward regression where we have our outcome, which is going to be Y, and that's measured at the individual migrant level, so the individual mover, in relative year T. So relative year just means relative to the period that you move. So we have 0 is going to be the year that you move. -1 is going to be the year before you move. 1 is the year after you move. And we're going to look at mover I in specialty S and relative year T, and we're going to have a handful of different outcome variables, but for now you can just think of this as like log spending. We're also going to have individual fixed effects. We're going to have origin by relative year fixed effects. What this is going to allow is essentially for there to be differential trends in prescribing behavior across different origins. It's also, you can think about this as restricting our comparison to physicians who start in the same origin, like we showed in the map. So it's going to be analogous to that. And then the primary treatment variable is this delta term, which delta is, again, you can think of as just the differences in average prescribing behavior between the destination D and the origin O. We do this at the specialty level, so we're going to be looking at a medical specialist who moves, how much average medical specialist in his or her destination changed versus his or her origin. And we're interacting that with these relative year fixed effects. So this is going to allow us to see, basically, in the years leading up to the move, is basically how your prescribing behavior is trending. Is that predictive of your move size? And then we're going to see, looking at these beta coefficients after the move, how does your prescribing behavior change depending on how big of a gap there is, how much your environment is changing. And the way this is formulated actually gives a pretty neat interpretation where you can imagine that we have some physician who is just an average physician in their origin. And think about a case in which this physician just does what they do, okay? They're not affected by their environment, so the environment's not going to have any impact on them. Well, if that's the case, then we would expect that you would continue to look just like the average physician in your origin, regardless of how big this delta term is. And so that's going to give us a beta of 0. So beta being 0 is telling us that the physician is not responding to what their environment looks like. On the opposite extreme, imagine the case in which this physician is going to just do whatever everybody else does in the area that they live. Well, what that's going to look like is the physician is going to go from having a value of y bar IOS to having a value of y bar IDS. Okay, so they're going to become exactly like the average physician in their destination. Well, if that's the case, that's going to correspond to a beta coefficient of 1. So seeing where beta lies between 0 and 1 is kind of pinpointing how much the physician is changing in response to their environment. The identifying assumption that we're going to make is basically a classic parallel trends assumption. It's got to be the case that absent the move, the trends in our outcome wouldn't have systematically varied with the size of the move. And we'll plot all these coefficients over time, of course, so you can evaluate that for yourself. Now, we're also, just to get a summary number on this, instead of just the event studies, we're going to consider another specification where we're essentially doing the same thing, but instead of having all these relative years interacted with delta, we're just going to have an indicator for what we call the transition period, which is the first 2 years of the move, and an indicator for the post period, which is any time after the first 2 years of the move. The reason we do that is because we see these kind of dynamic effects where your behavior takes time to change, but then it seems to settle down pretty much after the second year. And so we're going to consider this beta post coefficient as a summary measure of the total responsiveness that we see. So again, just to set expectations, we can think of these two extremes. So imagine doctors don't matter at all. Okay, they're going to do exactly what everyone else does in their place of practice. Well, then we'd expect 0s before the move and 1s after the move. Okay, because they're converging completely on what the practice style looks like in their destination. Okay, the other extreme is that doctors are the only thing that matter. Okay, so the nothing about the areas matter. I just have my practice style and I practice the way I practice. Well, then it doesn't matter what the delta is. I continue prescribing exactly as I did before. Okay, so getting into the results. Here's the first thing we look at is we look at log spending, and we're looking at again how this changes before and after the move. And so what we see here is we see again possibly a little bit of a pre-trend, but not too severe. And we see this slow growth in your prescribing that's happening after a move that seems to settle down after about the second year. If we show the coefficient from our second specification that we showed, we get a point estimate of 0.42. So to give you an interpretation of this, what this suggests is that moving to an area with 100% higher spending, you increase your own spending by 42%. Okay? Something that we think is worth pointing out just about these dynamics is this is broadly consistent with that physician learning model that I was talking about before, in which you don't have immediate changes in behavior because you have your practice style and it's evolving as you're kind of exposed to new information, although it seems to settle down relatively quickly. We also showed the same thing looking at spending per beneficiary. So this is this is log spending per patient that you write a prescription to. And again, we see broadly similar patterns. The summary coefficient is a little bit lower here. It's 0.29. So again, the interpretation of this is if you move to a place where they prescribe or where they spend 100% more per beneficiary, you increase your own per beneficiary spending by about 29%. We do a bunch of just kind of tests to make sure that what we're uncovering here isn't just an artifact of the way that we've constructed things. So what we're doing here is we're presenting the baseline coefficient. So this is for log spending. So this is that 0.42. And we're gonna kind of change the way that we do things. So this first set of results under the regression by move year, what we're doing there is we're estimating these regressions separately for each cohort. Okay, so we're looking at the cohort of doctors who moved in 2014, the cohort of doctors who moved in 2015, all the way to the cohort of doctors who moved in 2017. The rationale for this is really just to kind of comment on this more recent difference in difference literature with staggered adoption timing. If you're concerned about heterogeneous treatment effects potentially driving the event studies that we see, we don't see any evidence of really heterogeneous treatment effects. We also consider different definitions of our delta, which is again that primary treatment variable. So we allow it to vary by the year that you move. So instead of averaging across all years when we compute our delta coefficients, we again allow those to move. We consider doing this with a leave one out, which is really the right thing that we should be doing, but it's more computationally difficult. Turns out not to matter. We also consider dropping all prescribers who are what we consider low prescribers. These are the people who we can see their spending, but not the number of beneficiaries because it's somewhere between 1 and 11. And then the final thing we do here is just consider what happens if we enforce that physicians show up in every single calendar year of the sample. So we call this the balance in absolute time. And again, you see that these coefficients aren't changing all that dramatically from one specification to the other. Yes?
Do you still see the event study pattern?
So we have made these event studies for all of these. We thought this was easier to visualize, but yeah, so for if you're looking at somebody who moved in 2014, you only have one pre-period, right? If you're looking at somebody who moved in 2015, you only have one pre-period. But to the extent that you can kind of see what the pattern looks like, it's broadly similar.
I was just concerned for the learning story, if that's due to compositional changes or if that's true.
I see. Okay, so yeah, so when we look at the earlier movers, then we can actually see what's going on in terms of their dynamics. Yeah, I remember looking at this a while ago, and I think the pattern is. We don't think that this is compositional effects, but we could have a button for that in a future iteration. Yes.
So, I don't know, is there a way to reject the hypothesis that this is mostly driven by price differences?
So we are going to, this is mostly driven by, yeah, okay. So we've done,
Right, so aspirin is more expensive in San
Yeah.
Francisco.
no, that's a great question. In previous iterations of this paper, we've presented the results for log spending as well as just the number of claims, as well as the number of days supplied. It turns out that all those outcomes are super highly correlated and give you basically the same result. So I don't have that in this particular slide deck, but in at least the original version of the paper, we presented all of our outcomes, and it's not changing very much.
Sorry, what is it? Need one.
So when we compute these delta terms, we're taking the average of the destination, average of the origin. By leave one out, we're just excluding the actual migrant from that calculation, so that they can't be influencing things. It turns out it really doesn't matter because no particular physician is accounting for that much of total spending. Actually, we have exactly that. So physicians are a small fraction of total HHR spending. So whether we leave them out or not, it doesn't really change anything. The median is 0, like a strong 0. The mean is 0.05%. So not 5%, 0.05%. And yeah, this is. Let's see. Go back to details. We also see, we compute these deltas based on the entire sample of providers, which is like, 1.1 million different providers. There's a lot of providers in every HHR, so the minimum number in a HHR is 408. On average, it's 3,900. So again, this is getting this idea that no one physician is really driving what the deltas look like. We also have a large number of movers. So on average, we have 410 movers in each that start in each HHR. The minimum is 24. So we don't think that like small sample stuff is what's going on here. Okay, last thing on this particular set of results, we also consider different sets of fixed effects. Okay, so we've been asked about including not just relative year, but calendar year, also including, specialty-specific interactive trends. Again, the set of fixed effects that we include don't seem to matter very much. The one exception to that, the fixed effects that do seem to matter, is these origin by relative year fixed effects. Again, that's what's forcing our comparisons to be within physicians who start in the same origin. Without those, we get a little bit more of a pre-trend, which just speaks to the fact that different HHRs have different kind of spending trajectories. But these things don't seem to matter much. If we include information on physician characteristics, we also don't see much of a change in our main results. Okay, so to this point, what we believe we've established is that physicians are heavily influenced by their environment, but these persistent differences in physician-specific factors still explain a majority of the variation in drug spending that we observe. So a natural question, physicians move to a different place, they change their prescribing behavior to match the place that they move to. Is this a good or a bad thing? Well, we don't really have any comment on that because we don't know what the right level of spending is. What we would ideally do is look at, deviations from clinical guidelines in terms of your prescribing. So are you prescribing contraindicated medicines, for example? Now, we don't have any information about the patient side, so we can't do that. The best that we can do, though, is we can look to see, are you prescribing lots of brand medications relative to generic medications? Okay, so the idea here being that it's pretty well, it's recommended that when there exists a generic alternative, you prescribe that generic alternative. So we're going to look at that as kind of a proxy for, are you more or less likely to pick up good versus bad behavior? Okay. Okay. And then once we look at that, we're going to try to answer these remaining questions of, why are physicians changing their behavior at all? What's the mechanism there? But then also, why don't they change completely? Because remember, what we see is partial convergence. They do update their behavior, but they don't go all the way. So they don't, on average, physicians never become exactly like the environment that they move to. And so the way that we're going to do that basically is by examining physician and place characteristics that are associated with larger responses. Okay, so the first thing we look at here is our outcome variable now is just the generic cost rate. So what fraction of your spending is on generics as opposed to brands. And what we see here is similar to our main results. When you move to an area with 100% higher generic spending, you increase your own generic spending by 33%. Okay? The flip side of this is that if you move to an area with 100% less generic spending, you decrease your generic spending by 100%, or sorry, by 33%. Now, again, what we'd like to do is we'd like to see, are there potentially differential effects depending on what type of move you have. So, for example, if you move from a place, or if you move to a place with more generic prescribing, are you more likely to adopt that behavior than if you move to a place with lower generic prescribing? And the estimates here are a little bit noisy, so we kind of interpret these with caution. But essentially in panel A, what we're showing here is restricting our sample to our delta being greater than 0. So this means you're moving to a place that prescribes more generics, okay? And we're contrasting that response to moving to a place that prescribes less generics. Okay, and again, these are noisy, so if you don't love these results, that's okay, I'm sympathetic. But just looking at the summary measure, what we see is that physicians seem to be much more responsive when they move to places that are spending a higher fraction on brand name medications. So this is kind of a depressing result in that physicians seem to be more adoptive of bad behavior than good behavior. Again, in the one way that we can kind of proxy it, okay, with the limitation that this, that there are other behaviors that we might be interested in. As kind of an ancillary result here, we want to look at how much the difference, or how much the decision to prescribe generics versus brands can explain our total spending results. So what we do here is, instead of regressing the generic share on the difference in generic shares between places, our delta coefficient is going to be the change in log spending, and we want to see how does your generic share change when you move to a place that has higher total spending. Okay, and what we see here is that when you move to places that have higher total spending, you decrease the fraction of your spending on generics, so you're prescribing more brands. Okay, this coefficient, the way to interpret this is if you move to an area with 100% higher spending, you decrease your generic share by 1.2%. Okay, so to try to give just a back of the envelope of how much this could possibly explain in our total spending results, we look in the entire sample, and we look at just the relationship between spending and generic share. We get an estimate from that, and then we say, okay, 100% higher spending, or 100% higher spending area is associated with you increasing your own spending by 42%. It's also associated with you increasing your brand spending share by 1.2%. And what we end up getting is a number of about 10%. So about 10% of the change in spending can be attributed to just the decision to prescribe brands versus generics. Okay, now in terms of trying to figure out why is any of this happening, we first look to see what physician characteristics can, in some sense, explain the extent to which these prescribers are malleable. Okay, so we do a couple things, or we plan on doing a couple things. The first is just to rerun regressions by different splits, okay, so to kind of cut up the data. It turns out that if we consider things like medical school, credentials, or gender, we don't really see any heterogeneity. So it's not the case. We had thought that maybe if you went to a higher ranked medical school, you'd be more set in your ways. Turns out that's not the case. We also don't see anything, again, by MD versus DOs. We don't see anything by male, female. Where we do see something is by experience. Okay, so here, what we're doing is we're just binning experience into 5 bins, and then we're seeing how do your estimates change in terms of your responsiveness. So again, what these coefficients are saying is basically how much do you respond to a 1% change in the spending of your environment. And what we see is we see much higher responses for less experienced physicians. Okay, so less experienced physicians, 1% change in spending, they increase their own spending by 0.6%. But these people who have a lot of experience, a 1% change in area spending is only associated with like a, I don't know, 0.18% change in spending. Okay, so the takeaway from this is just that the more experienced a doctor becomes, the less malleable their practice style is. This also fits in pretty nicely with that paper that I was telling you about for physician learning. Again, as you've accumulated more and more experience, the kind of marginal contribution of additional changes in your environment isn't going to be worth as much. So you would predict that less experienced physicians are going to be more responsive. Okay, we are in the middle of trying to figure out the specialty results, but we don't have that yet. We also, as soon as we're done cleaning up the residency, we want to look at that as well, okay, to see if where you did your residency impacts your responsiveness. The next thing that we haven't done yet, but are planning on doing, is just decomposing the physician fixed effect. So seeing what different characteristics are associated with bigger or smaller physician fixed effects, but don't have anything on that yet. So, yes.
One other element of heterogeneity I'd be interested in is the number of patients that you're prescribing from Medicare Part D. Like how much of your income is reliant on Part D?
Yes, so that's something we would love to know, but we don't have that, although we'd be really interested if we could, because we see the number of beneficiaries that you prescribe to, but we don't see your total patient pool, right? So I don't know how many patients a doctor sees over the course of a year. I don't know how many patients, I don't know their relative split between Medicare, Part D, and other. Although if you have a suggestion on where to find that would
I think assuming it's like relatively
similar to parts A and D.
Just using the numerator is fine.
Sorry, say that again?
I think just using the number of Medicare Part D beneficiaries is fine with enough to suggest.
Okay. Well, we can get that, right? So we can think about that. In terms of like what characteristics of the environment matter, the first thing we look at is pharmaceutical marketing. So we want to know, if you move to an area where there's lots of pharmaceutical marketing going on. This comes from the open payments data set. Does that change your responsiveness? Here, all we're doing is we're including an interaction between relative year fixed effects and the gap in pharmaceutical payments between your origin and destination. So panel A is just the baseline that we showed you before. Panel B is including this control, and it makes essentially no difference, which is somewhat interesting. The next thing that we do is we look to see, okay, holding fixed the change in spending, what happens if you move to an area with higher pharma payments or lower pharma payments? And again, we don't really see any evidence of strong differences in how much you adopt the behavior of your environment, depending on how much pharmaceutical reps are spending in that area. Yes?
So how are you defining the pharmaceutical spending?
So all we're doing is we take the open payments data set, and we're just totaling up the total amount that was spent in detailing to doctors across the board in that hospital referral region in that year. I'm trying to think of other things. Something that was surprising to me just dealing with this data for the first time is how small the pharmaceutical payments are on average. So, there are some that are outrageously expensive, but the median payment is like $15 or something, or $25. It's, buying lunch while you do a presentation for the physician.
Yeah, I just wonder if it's not necessarily like the payments on marketing, but the relationships with the pharmaceutical reps themselves.
Yeah. Yeah, so that could very well matter, but we just can't quite see that. But in terms of the dollar amounts of the payments, we don't see anything. But that's a fair point. Eventually, we want to look at the competitiveness of the area, but haven't got there yet. We also are in the process of looking at patient characteristics, so in particular risk scores and demographics. We've actually been messing around with that for a couple of weeks at this point, and so far haven't really found big changes depending on what the patient population looks like, but don't have results that are ready to share. One other thing that we wanted to consider was just how patient demand might affect things. And we don't have a great way to measure this, but what we thought about doing was just looking at heterogeneity by drugs, with the idea being that, for some drugs, patients are going to have, they're going to care a lot about them. Some drugs they're not. Narratively, this might not be the right place to put this, but here's what we find. Okay, so again, what we're doing here is we're showing these different classes of drugs that we got from the medical expenditure panel survey. The kind of gray histogram is just showing the fraction of total spending on each of these drug classes. So for example, about 15% of total spending is spent on anti-diabetics. And then we just look to see, relative to the baseline responsiveness, how does this change for these specific classes? And a few things that we notice is that for cardiovascular drugs, for chemo drugs, and for statins and for benzodiazepines, we see that doctors seem to be less responsive. It's not entirely clear what the story is there. The one place where we actually see a statistically significant difference, where physicians seem to be more responsive, is for painkillers. Okay, so for analgesics, and we've looked at this specifically for opioids, and find that doctors seem to be more responsive to their environment there. So it's not entirely clear whether there's a story there. We've also split this by experience, so comparing the least experienced bin of prescribers to the most experienced bin. This was interesting. Someone suggested that we look at ED drugs, and it turns out that the most experienced doctors, the only real difference in responsiveness is for these classes of drugs, which again, we're not entirely sure what to make of, but it seems like basically across the board, less experienced doctors seem to be more responsive in to their environments.
We have regulations both around the generics and around the opioids, probably around others. So that'd be
so could it be differences in these
fairly easy to get state level database on.
Yeah, we can look at that. We can. Yeah, that's a good suggestion. So we can look if the state has a strict prescription drug monitoring program, do we see you moving more in line with what other physicians are doing? Yeah, we can do that.
And then also on the generic substitution, some states I think have a law. Pharmacist has to substitute.
So we've actually looked into that. So there are, in terms of the literature, there seem to be two laws that people are thinking about. One, which is just saying, so in every state except Oklahoma, I believe, the pharmacist is allowed to substitute towards a generic, but that can be overridden by the patient. So the patient can say, no, I want the brand. The difference, okay, so the way these laws work is there are some states where it is mandatory for the pharmacist to try to dispense the generic, which again can be overridden. So they refer to those as permissive versus mandatory substitutions. And then there's another set of laws which basically have to deal with can you assume that the patient consents to receiving the generic, or do you have to get explicit permission? So what we've done there that I don't have on this in this slide deck for the brand versus generic costs specifically is we said, okay, let's look at moves that are within the same legislative kind of type. Okay, so only looking at people who move from mandatory to mandatory or from permissive to permissive. And see, is that what's driving the changes in brand versus generic? And we actually see surprisingly little differences there. That it doesn't seem to be the laws that are explaining our brand versus generic finding, which we thought was interesting because we thought similar to you that maybe the regulatory environment was what was driving this, but so far we haven't seen evidence of that. Okay, the last thing that we're planning on doing.
The other view, I wasn't expecting a view, I was just asking, but the other view is that the insurance plans already, because you're getting this through Part D, everybody's insured here.
Mm-hmm.
And the insurance plans, this is their policy. If there's enough of a medical substitution between these two things that the regulators are willing to say, pharmacists, you can swap them. Well, the insurance company's already there.
Yeah.
And
Yeah.
they're saying swap them.
Yeah. So one thing we've thought of, or one thing that we are planning on doing, but has been a bit of a pain to get rolling, is to look at these different contracts and to see, what are the different insurers in this area, and can the dominant insurers in an area kind of explain any of what we're seeing. We don't have results on that.
They all should do that, and they all want to make money.
Yeah.
And then there's competition. That boils down to they want to have low premiums.
Yeah. So right now I don't have anything to comment other than to say that just that's on the radar, and so we want to see if these differences in contracts can actually explain anything. But good suggestion. So just to wrap up, nothing that you haven't seen in the last however many minutes, but we find that physician prescribing behavior is, again, heavily influenced by their environment, which seems to be true of both bad and good behaviors. Broadly speaking, we think this is consistent with a model in which physicians are learning behavior from their new environment. Interestingly to us, at least so far, beyond just spending, the characteristics of the place don't seem to predict the extent to which physicians are responsive. And then, just to wrap up, our kind of headline number is that differences in physician-specific factors can explain about 60% of the cross-sectional variation in Part D spending. Okay, thanks. Any other questions?